All right, so I'll give you a recap of the blood supply for the upper limb, starting with the arterial blood supply, then we end with the venous drainage of the upper limb, both the superficial and the deep veins. Right. So um, blood supply, essentially, the main pump is the heart. And from the heart, we have an ascending aorta, arc of the aorta, which then continues as descending aorta, better known as the thoracic aorta. But from the arc of the aorta, we get three main branches. And the three main branches are there's a brachiocephalic trunk, there's a left common carotid, then there's a left subclavian. The brachiocephalic trunk on the right, it's the one that will give rise to the right common carotid and the right subclavian. And where it divides to give us these two branches, it's behind the right sternoclavicular joint. So behind your right sternoclavicular joint, that's where you're going to have the brachiocephalic trunk dividing into a right common carotid and a right subclavian. Right. Then on the left side, the left common carotid and the left subclavians, they're coming off as direct branches from the arc of the aorta. Right. So these arteries, by now you must know that the common carotids, um, they're going to they're going to go to the head and neck. Then the subclavians, they supply partly the thorax. Then they also supply part of the neuronal circulation for the brain via the vertebral artery. And then these subclavian arteries, they're the ones that continue as the axillary artery, where we start off the description of the blood supply for the upper limb. So subclavian artery, it's the outer border of the first rib. Remember, outer border of the first rib is one of the boundaries for the apex of the axilla. So at the outer border of the first rib, the subclavians will now be entering the axilla. So they change name and they become axillary artery. Right? So this is one artery that is just changing name. So subclavian artery, having been divided into three parts by the scalene muscles, into a first part with three branches, a second part with 0 or 1, depending on text, or maybe 2, let's say 2, then third part, let's say 0 for the purpose of this video. Um, that subclavian then continues as axillary at the outer border of the first rib. And your axillary artery is going to be this. So I think you can look, this is the first rib here, where it's labeled lateral margin of the first rib here. That's where the subclavian will change name to become the axillary artery. And it is at that point where the apex of the axilla also starts. Right? So this axillary artery, if you have done the axilla, by now you should know that it's within an axillary sheath. Axillary sheath, you know that it's made from prevertebral fascia, which is deep fascia coming from the neck, which you remember that it floors your posterior triangle. Right. Then this axillary artery you divide into three parts. But what divides it into three parts is this muscle, which is the landmark for the axilla. And this muscle is going to be the pectoralis minor, which originates from the third, the fourth, and the fifth ribs, then inserts into the tip of the coracoid process. Function-wise, it's going to depress the shoulder. So this pec minor divides the artery into three. There is the part of the artery from the lateral border of the first rib where it starts to the margin of the pec minor. That's the first part. There's a part which goes behind the pec minor. That's the second part. Other texts will say that that part can also go anterior to to the pec minor, right? Then the third part is the part that extends beyond the pec minor all the way to the lower border of the teres major, where axillary artery will change name again to become the brachial artery. So axillary artery is from lateral border of the first rib to the lower border of the teres major. At the lateral border of the first rib, it was a continuation of an artery that we're calling subclavian. Then at the lower border of the teres major, it then continues as the brachial artery. The brachium is the arm, meaning the brachial artery will be the artery for the arm, right? So, funny enough, your axillary artery is quite simple. The first part gives you one branch. The second part gives you two branches. The third part gives you three. Right? From the first part, we have the superior thoracic artery. The name is self-explanatory. It supplies the thoracic wall. From the second part, we have two arteries. Those two arteries are quite dear or maybe important because on top of supplying upper limb and thoracic structures, they also give blood supply to the mammary gland. Right. So second part gives us thoracoacromial artery and the lateral thoracic artery. So second part has thoracoacromial, then the lateral thoracic. And I'm sure by now you remember the very first lecture that we had on the pectoral region. I talked about something called clavipectoral fascia. And I told you that we had 4 or 5 things that pierce clavipectoral fascia. And of those 4 or 5 things that pierce clavipectoral fascia, using the mnemonic CALL, CALL, the A was for an artery. And that artery, I remember telling you that it comes from the second part of the axillary artery. So that artery is your thoracoacromial artery, right? So second part of your axillary artery gives us thoracoacromial and lateral thoracic artery, right? First part, we say it's superior thoracic artery. Then third part, 3 branches. So first part, 1 branch. Second part, 2. The third part gives us 3. The 3 branches from the third part, you have 2, which are humeral circumflex arteries. So there is anterior and there is posterior humeral circumflex arteries. And those humeral circumflex arteries, you remember that they wind around the surgical neck of the humerus. The surgical neck of the humerus is the most commonly fractured site, hence surgical neck, right? And you should also remember that the posterior humeral circumflex, which is larger than the anterior, travels within the quadrangular space in company of a nerve. The nerve is the axillary nerve. So axillary nerve and the posterior humeral circumflex artery, they will travel together in the quadrangular space. If you remember how you come up with the boundaries of the quadrangular space here. Then the third artery that comes off the third part of your axillary artery, which so happens to be the largest branch of the axillary artery, is an artery called subscapular artery. Right? So subscapular artery, the one that I've highlighted here, that's the largest branch of the axillary artery. It comes off the third part of the axillary artery. Right. So a recap, first part has 1 branch, highest thoracic artery. Second part has 2 branches, that is thoracoacromial and your lateral thoracic. Then third part has 3 branches, anterior humeral circumflex, posterior humeral circumflex. Then it also gives us your subscapular artery. Then also remember, when you are doing brachial plexus, the brachial plexus, in particular the cords of the brachial plexus, they're intimately related to the axillary artery, such that in relation to the first part of the axillary artery, we say the cords all lie above and lateral. Then you name the cords in relation to the second part, such that lateral cord is lateral, medial cord is medial, posterior cord is posterior. Hence, branches that come off the posterior cord of the brachial plexus, they are going to be posterior to the artery. Those from the medial will be medial, those from the lateral will be lateral. Right. Okay. Then I said axillary artery ends at the lower border of your uh, um, teres major, which is here. Right. So at the lower border of the teres major, this is where your axillary artery ends and changes name to become brachial artery. Right. For the purpose of completeness, that is what I was describing, to say arc of the aorta. On the left side, it gives us left common carotid and left subclavian. But on the right side, I get a brachiocephalic trunk. Brachiocephalic trunk is the one that divides behind the right sternoclavicular joint to then give me right common carotid and right subclavian. Right. Then the subclavian at the outer border or the lateral border of the first rib, it changes name to become your axillary artery. Right. Great. Questions so far about the axillary artery? I'm assuming I'm converted. People will know already.
Dr. G.
Yes.
You're saying something about things that pace the clavipectoral fascia. Say there are 4, 5. What's the
Oh yeah.
fifth one?
So you know 4.
Yeah.
So tell me the 4.
Cephalic vein, thoracoacromial artery, lateral pectoral nerve, and infraclavicular lymph node.
Lymph vessels, not lymph nodes.
Okay.
So
What's the
if
difference?
sorry,
Difference between lymph vessels and lymph nodes?
that's a good question. Lymph vessels empty in a lymph node. So lymph vessels, they carry the lymph towards the lymph node. Those are what we call um the afferent lymphatic vessels. They carry the lymph towards the lymph node for it to be cleaned basically in layman language. Then efferent lymphatic vessels carry now the lymph from the lymph node back to the veins. Because lymph is excess tissue fluid. If you remember your physiology, lymph is excess tissue fluid, which you don't just take back to the veins. You need to have it cleansed, then take to the veins. So the afferent lymphatic vessel will carry the lymph towards the node. The node will clean, then the node will be drained by an efferent lymphatic vessel, which then join to form the larger lymphatic vessels that we see in the thorax. We'll talk about the thoracic duct that ends by draining into the veins. So fifth item that pierces clavipectoral fascia. It's a bit controversial, but it's there. It's the medial pectoral nerve. Right. Do you have a comment on it? Do you think it's wrong to say medial pectoral nerve also pierces clavipectoral fascia? Do you think it's wrong to say clavipectoral fascia is pierced by medial pectoral nerve? Or you have no argument? Hello?
I have no idea. I have no
Oh, it,
argument.
oh, it does. Um, so maybe I'll diverge a bit from this and try and use common sense for you guys. Let's say this is pec major. This is pec minor, right? Then you remember that clavipectoral fascia encloses two muscles. The two muscles enclosed by clavipectoral fascia include the subclavius and the pec minor. So it's going to be like this, right? Then you say lateral pectoral nerve pierces clavipectoral fascia, right? And that lateral pectoral nerve will go to the pec major on top. If you also have medial pectoral nerve will pierce clavipectoral fascia because it wants to supply that muscle, which is within the fascia. Then it also goes all the way to supply the muscle superficial. So you can supply the muscle enclosed by something without piercing it. Do you get the sense?
Yes.
Okay. But that again depends with books. So take it religiously. Right. So brachial artery is now the artery for the arm, and it's a continuation of the axillary artery, like I showed you in the previous picture. It's a continuation of axillary artery at the lower border of your teres major. And the first branch from the brachial artery, which I want you guys to remember, since you also do lower limb. Lower limb is just an upper limb that's rotated in the opposite direction and is things with different names, but almost the same structures. So brachial artery gives me an artery, a branch here, um, this one, which is called the profunda brachii artery. This is the first branch of the brachial artery, and it arises from its posteromedial surface. Profunda means deep. Brachii means arm, because I'm referring to the brachium. So this is an artery that is supplying deeper structures in the brachium, which is the arm, and deeper in this sense is in the sense that brachial artery is on the anterior forearm. If you're now saying profunda deep, I'm going to the posterior arm. So profunda brachii arises from the posteromedial surface of your brachial artery, and this one, and it supplies the structures in the posterior compartment of the arm. If you remember the spaces, this profunda brachii will travel with the radial nerve within the spiral groove in an interval called the triangular interval. It is in that same radial groove where radial nerve injuries will lead to a wrist drop. Right, so just remember, profunda brachii is an artery for your posterior compartment of the arm. Then this brachial artery will also give me a nutrient artery for the humerus. Then it also gives me what are known as ulnar collateral arteries. I'll talk about this shortly when I do the elbow joint anastomosis. So you have superior ulnar collateral, which if you remember the arm, you know that superior ulnar collateral artery will travel with the ulnar nerve, and together they will pierce the medial intermuscular septum. Right. So you have superior ulnar collateral. If you say superior, that means somewhere you're going to see an inferior. So you also have inferior ulnar collateral coming off the brachial artery. And of course, this is an artery for the anterior arm. So it is going to give you muscular branches for muscles in the anterior arm, which includes your coracobrachialis, then the brachialis, then you also have the biceps to make them three, right? Okay. Any questions on the brachial artery? Quite simple. Any questions on the brachial artery before I do the elbow joint anastomosis?
No.
Okay. We'll also look for a picture for elbow joint anastomosis. Why do we have an elbow joint anastomosis? The moment you make sense of things, your life gets really easy. Why do you think we have an elbow joint anastomosis? This here, it's showing us the brachial artery in front of the elbow joint at the level of the neck of the radius. It divides into a larger ulnar artery and a smaller radial artery. Okay. You guys haven't answered me. Why is it that we have an anastomosis around the elbow? Why not just have the brachial artery continue all the way down? Do any of you guys here go to the gym?
I go to the gym.
You go to the gym. Why? So why should you? What do you think is the reason for having this anastomosis that I'm about to show you here?
I have no idea.
If you're lifting weights, what do you think will happen?
Suppress the arteries.
So you compress the arteries, yes. And if you compress the arteries, what would have happened? If you compress the arteries, oh, you would have done what? Because the moment you flex this elbow joint, you compress the brachial artery. So if you don't have an anastomosis, basically no blood will come to the forearm, no blood will come to the hand, and you get ischemia. Right. So this picture here on the far, maybe for you guys on your screens, far right. This is the anastomosis. And basically, we divide this anastomosis into 5 parts. Right? There's an anastomosis in front of the medial epicondyle. There's an anastomosis behind the medial epicondyle. There's an anastomosis in front of the lateral epicondyle. There's an anastomosis behind the lateral epicondyle. There are now 4. The 5th one is the anastomosis that is just above the olecranon fossa. And basically, this anastomosis at the elbow joint is happening between branches of the brachial artery, the radial artery, and the ulnar artery. So basically, you can say it's an anastomosis between the brachial artery and its branches and branches of its branches. Because remember, I said brachial artery is the one that ends at the level of the neck of the radius by dividing into a larger ulnar artery and a smaller radial artery. right? So this is the anastomosis here, right? So in front of the medial epicondyle, I have branches of the or maybe branches of the brachial, which is the superior and the inferior ulnar collateral arteries that I was mentioning. The anastomose with a branch of with this one shown here, with a branch of the ulnar artery called the anterior ulnar recurrent artery. So anterior ulnar recurrent meaning it is a recurrent course going back up instead of going down like the other arteries that are going to the periphery. So the collateral branches of the brachial will anastomose with the anterior ulnar recurrent artery in front of the medial epicondyle. Then behind the medial epicondyle, the same collateral arteries from the brachial, which is superior and inferior ulnar collateral, they will anastomose with another branch of the ulnar. This time around, we call it posterior ulnar recurrent because it's going behind the medial epicondyle. Then for the lateral side now, we now include the the profunda brachii, which is a branch of the brachial. That profunda brachii gives us this very important artery here that we call the radial collateral artery. Right. This radial collateral artery will anastomose with the radial recurrent artery, something that you can clearly see from this picture here. So radial recurrent artery, a branch of the radial artery, will anastomose with the radial collateral artery, a branch of the profunda. And this is happening in front of your lateral epicondyle. Right. Then behind the lateral epicondyle, you talk about another branch of the profunda, which is called posterior descending artery, anastomosing with an interosseous recurrent artery, which comes from an artery called common interosseous artery. Common interosseous artery, I'll mention it shortly as a branch of the ulnar artery. Then I won't mention the one above the olecranon fossa. But take home message here, we have 5 large arteries anastomosing here. Though the main point is it's just brachial artery and its branches. The 5 major arteries anastomosing here are number 1, the brachial, number 2 and 3, its terminal branches, the radial and the ulnar. Number 4, it's the profunda brachii, which is the largest branch of the brachial. Number 5, it's the common interosseous artery. Common interosseous artery gives us, or it's given off from the ulnar artery in the forearm. Right. Okay. So brachial has ulnar and radial artery in the forearm. Right. Then ulnar is the largest. So ulnar will give us an artery called common interosseous. Then this common interosseous artery will further divide into an anterior interosseous and a posterior interosseous. Right. I'll assume people are still following. Okay. Then specific branches, anterior interosseous will give us blood supply to structures in your anterior compartment of the forearm. Right. Then radial artery, I said, is the smaller terminal branch at that level of the cubital fossa. Because remember, in the cubital fossa, there is the bifurcation of the brachial artery. That's where all this is happening. Right. Okay. Then I won't go much on those two. Right. Does anyone know what happens to the radial and the ulnar artery in in the hand? Does anyone want to hazard a guess? But I'm sure you know from what I taught you on the hand.
Yeah, I think it forms arcs.
Axe, okay. Mm-hmm. Your story is like so who's the president of Zimbabwe? Then you tell us we have a president without the name. So please quantify and explain.
Okay, with a deep and superficial palmar arc. The superficial one, it's made up by a large branch from the ulnar from the yes from the ulnar artery and a small branch from the radial artery. Then the deep one, it's made from a large branch from the radius artery and
Radio
a small
artery,
branch
yes.
from the ulnar artery.
Mm-hmm. So
I'm
all
not.
this is happening on the palm, right?
Then you say
So all this is happening on the palm.
yeah.
So how then does the radial artery gain access to the palm? Because radial artery will start by going through the anatomic snuff box where you can feel its pulsations. How then do you end up with the radial artery on the palm of the hand, yet it starts on the dorsum of the hand? Do you know the specific pathway? That same specific pathway, we're going to see it in the foot when we do the dorsalis pedis artery. By then, I'll just be telling you that dorsalis pedis reminds us of radial artery. You need to know what happens to the radial artery. So where does the radial artery pass through? Does it have to do with two heads of muscles? Giving you hints. So it passes through the two heads of the first dorsal interosseous. Then it will pass through the two heads of the adductor pollicis. Then it arcs. So passes through the two heads of the first dorsal interosseous, then the two heads of the adductor pollicis. Right. And there's this pictorial representation of the distribution of those arteries. Right. Okay. Looking for some specific picture. Then for veins in the upper limb, we divide our veins into superficial and deep. Superficial veins are in the superficial fascia, and these superficial veins they don't normally lie in regions where there is pressure. So they normally tend to run away from the palm of the hand, such that we have a venous arc on the dorsal aspect. So all these veins on the palmar aspect of the hand, they drain to the dorsum of the hand into this dorsal venous arc. This dorsal venous arc at the wrist, in the wrist region, on the lateral side, it continues as the cephalic vein. On the medial side, it continues as the basilic vein, both initially being superficial veins. Cephalic vein will remain superficial until when it's about to drain. Unlike basilic vein, which at the at just after the elbow joint it will become deep. I'll remind you this again when we do lower limb, where you see the great saphenous and the short saphenous resembling these two, where one starts superficial and ends superficial, the other one starts superficial, goes deep at some point. Right. So cephalic vein is the one that starts off from the lateral end of this one, the lateral end of your dorsal venous arc. It crosses in the roof of the anatomic snuff box. Right, it will cross in the roof of the anatomic snuff box, and it travels in the superficial fascia. At some point, it will be lateral to the biceps, still superficial, and when it reaches the lower border um, of the pec major, it pierces the deep fascia to lie in a groove that you find between your um, deltoid and your pec major. That groove will be your deltopectoral groove. Right. So cephalic vein superficial will pierce deep fascia at the pec major to go into the deltopectoral groove. Then it empties into the axillary vein. But how does it empty? It will start by piercing the clavipectoral fascia. Remember the core, the mnemonic C is cephalic vein. Right. Basilic vein, on the other hand, basilic vein is the one on the medial side, and this one midway up the arm, it pierces the deep fascia to join the vena comitatus of the brachial artery. Vena comitatus, I'll talk about them when I do the deep veins. They'll join the vena comitatus of the brachial artery to form the axillary vein. So axillary vein is formed where axillary artery ends. Axillary artery ends at the lower border of teres major, and remember veins are going back towards the heart. So at the lower border of the teres major, you will form the axillary vein, which at the outer border of the first rib will change name to subclavian vein. The same way the subclavian artery changed name to axillary artery at the lower border of your um at the lower border of your not lower border, but at the lower border of outer border rather of the first rib. Right. Then deep veins, we have vena comitatus. These are paired veins that follow the large arteries, which is the brachial, the radial, the ulnar, the muscular arteries. They have vena comitatus. They are paired veins that travel with them. Right. Okay, so then most importantly for clinical work, we have what we call the median cubital vein. This one. The reason why we have a median cubital vein, number one, the cephalic vein, where it goes to drain into the axillary vein, it's at right angles. That means there's poor drainage, right? So, because imagine you want to drain water from the floor to a pump on the roof, which you are draining at right angles. That's almost a poor drainage system. So some of the blood from the cephalic vein will be shunted to the basilic vein, which is more direct drainage. And that's why we have a median cubital vein. Then clinically, it's important because we can use this for medication, right? Then, wow, has anyone ever wondered why it's safe to pierce into the median cubital vein at the cubital fossa there, though we know that there is the brachial artery within the cubital fossa? Anatomically, what's the reason why there's nothing wrong with it? Anyone? Going once, going twice. So anyway, remember contents in the cubital fossa are protected by the bicipital aponeurosis, which separates those contents of the cubital fossa from the median cubital vein in the superficial fascia. So really, will you need to worry about piercing your needle into the brachial artery, right?